Good morning. These are my declarations. The aims of systemic therapy are either to control symptoms of hormone secretion, to reduce symptoms relating to disease bulk, or to prolong progression-free and overall survival, or a combination of two or more of these aims. Secretion of serotonin, which occurs in approximately 20% of patients with neuroendocrine tumors, causes carcinoid syndrome, consisting mainly of flushing and diarrhea. Loperamide can be useful in reducing the diarrhea frequency. However, the mainstay of management of carcinoid syndrome would be the use of somatostatin analogues, either octreotide or lenretide. More recently, Telotrostat, which is a tryptophan hydroxylase inhibitor, has been licensed for use in diarrhea which is resistant to somatostatin analogues. Somatostatin analogues are either short-acting or long-acting versions. Patients with carcinoid syndrome are usually given long-acting lenretide or octreotide every 28 days, and the use of short-acting octreotide can be used in severe cases with breakthrough symptoms. Two trials have investigated the role of Telotrostat in carcinoid syndrome and have demonstrated that it can reduce bowel frequency as well as reduce urine 5-HIAA secretion. Telotrostat 250 milligrams 3 times daily is now licensed for use in patients with diarrhea which is refractory to somatostatin analogues. Neuroendocrine tumors can secrete other hormones, causing specific syndromes. Medical treatment with metarapone can be used for Cushing's syndrome, high-dose PPIs for gastrinomas, diazoxide for insulinomas, and steroids for lipomas. Treatments available for patients with symptoms due to large volume disease include local therapies such as surgery, ablation, embolization, and SIRT, or systemic therapies including molecular inhibitors, cytotoxic chemotherapy, and peptide receptor radionuclide therapy. However, it must be highlighted that on the whole, response rates to most systemic therapies are generally low, and therefore in patients with very symptomatic bulky disease, they may benefit more from localized therapies. The main aim of systemic therapy in most patients with neuroendocrine tumors is to prolong progression-free and overall survival. There are a number of systemic therapy options, including somatostatin analogues, molecular inhibitors, radionuclide therapy, and cytotoxic chemotherapy. Two randomized trials have investigated the role of long-acting somatostatin analogues in neuroendocrine tumors. The PROMID trial, which recruited 85 patients with unresectable or metastatic grade 1 midgut NETs, which were either functional or non-functional, to receive either octreotide 30 mg 4 weekly or a placebo. Secondly, the CLARINET trial recruited 204 patients with unresectable or metastatic grade 1 or grade 2 pancreatic or mid and hindgut NETs, which were non-functional, to receive either lenretide 120 mg 4 weekly or placebo. both trials consistently demonstrated that long-acting somatostatin analogues significantly prolonged time to tumor progression or progression-free survival, with a hazard ratio of 0.34 in PROMID and 0.47 in clarinet. It is important to note that PROMID and clarinet demonstrated that the benefit was similar between functional and non-functional tumours, pancreatic and GI NETs, and grade 1 and grade 2 tumours. Over the past 20 years, there has been exponential increase in the use of molecular inhibitors in the treatment of many malignancies. Everolimus is an M2 inhibitor which has been investigated in 3 randomized trials in neuroendocrine tumours. RADIANT-2 recruited 429 patients with well-differentiated mid-gut tumours with carcinoid syndrome to receive either everolimus 10 mg daily together with 4-weekly octreotide 30 mg or placebo with 4-weekly octreotide 30 mg. The primary endpoint was progression-free survival, but this was pre-specified at less than 0.0246, which was adjusted for 2 planned interim analyses. Although there was a 5.1 months improvement of progression-free survival with everolimus and a p-value of 0.026, this just fell short of the 0.0246 target, and the trial had to be reported as not fulfilling the primary endpoint. This waterfall plot demonstrates there were more patients having minor disease reduction with everolimus than with placebo. RADIANT-3 included 410 patients with grade 1 or grade 2 pancreatic NETs randomized to either 10 mg of everolimus daily or a placebo. It demonstrated a 6 months improvement of progression-free survival with a hazard ratio of 0.34. The waterfall plot is remarkably similar to RADIANT-2, showing more patients with everolimus having minor response. RADIANT-4 included 302 patients with non-functional grade 1 or 2 GI or lung NETs to receive either everolimus or placebo in a 2:1 ratio. There was a 7.1 months improvement in progression-free survival with everolimus with a hazard ratio of 0.48. And a waterfall plot remarkably similar to RADIANT-2 and 3. Therefore, everolimus is a highly active treatment in prolonging progression-free survival in a wide range of NETs. It works in functional tumours in combination with somatostatin analogues, in pancreatic neuroendocrine tumours, and in non-functional lung and GI neuroendocrine tumours. However, it is not licensed in combination with somatostatin analogues in functional tumours, as it did not fulfill the primary endpoint of the trial. Sunitinib is a multi-targeted tyrosine kinase inhibitor. A 171 patient randomized trial allocated patients to 37.5 mg daily or placebo. It improved progression-free survival by 4.9 months from 5.5 to 11.4 months with a hazard ratio of 0.42. The waterfall plot showed more patients receiving sunitinib had minor responses than those receiving placebo. Lenvatinib is a VEGF and fibroblast growth factor receptor inhibitor. Is licensed for thyroid, liver and renal tumours. Recent presented data from a phase 2 trial of 101 patients of progressing GI and pancreatic NETs treated with lenvatinib 24 mg daily showed overall response rate of 29%, broken up to 16% in GI and 44% in pancreatic NETs. These data are extremely promising, however, phase 3 studies are yet to begin. DOTA-based peptide receptor radionuclide therapy, otherwise known as PRRT, has been used in neuroendocrine tumours for many years. The NATA-1 trial randomized 229 patients with well-differentiated somatostatin receptor positive mid-gut NET, which were progressing on somatostatin analogues, to either 4 cycles of 177-lutetium dotatate PRRT 7.4 gigabecquerels with octreotide 30 mg 4 weekly or octreotide 60 mg 4 weekly. Data initially published in 2017 demonstrated that PRRT significantly improved progression-free survival with a hazard ratio of 0.21. The final results of this trial were presented at ASCO this year, showing the maintenance of the hazard ratio of 0.18, and the overall survival showed a difference between 36 and 48 months. However, this was not statistically significant. The overall response rate in patients receiving PRRT was 18% compared with 3% in those not receiving PRRT. Finally, cytotoxic chemotherapy has been used for neuroendocrine tumours for many years. However, there is a lack of well-designed modern phase 3 randomized trials, as a lot of the published data date back to the 1980s and 90s and are from retrospective single-center studies. However, when reviewing the published evidence, most of the data supporting use of chemotherapy are for pancreatic neuroendocrine tumours, where response rates of between 30 and 60% may be achievable. This response rate appears significantly less in mid-gut neuroendocrine tumours. Active drugs include alkylating agents such as streptozicin, dacarbazine and temozolomide, and antimetabolites such as 5-FU and capecitabine. It appears that combination of treatments such as streptozicin and 5-FU or capecitabine and temozolomide appear more effective than single-agent drugs. a relatively recent randomized phase 2 trial of 144 patients allocated to either single-agent temozolomide or a combination of temozolomide and capecitabine. This demonstrated progression-free survival of 22.7 months in favor of combination compared with 14.4 months with single-agent temozolomide and a hazard ratio of 0.58. Overall survival hazard ratio was 0.41. Temozolomide and capecitabine is now the standard of care in most neuroendocrine tumor centers for patients receiving systemic chemotherapy. I have presented data on the use of somatostatin analogues, molecular inhibitors, PRRT, and chemotherapy in neuroendocrine tumors. The reality is that there's often multiple options available to recommend for the patient, especially in one who has been newly diagnosed. The question is, how does one choose which one to go for? I have listed some of the factors used to consider this decision. In the end, it is a balance between effectiveness of the treatment and its toxicity and the quality of life of the patient, especially in a group of patients who are expected to survive for many years with their disease. Therefore, it is important that the entire multidisciplinary team is involved with this decision, and particularly the clinical nurse specialists who represent the patient and their interests. However, many of these treatments are financially costly and may not be available in all cases. I have listed what is currently funded by the NHS and in what circumstance. To summarize, there is a variable number of active systemic treatment options for neuroendocrine tumors depending on the primary site of disease. Randomized trial data demonstrate improved progression-free survival rather than overall survival in many cases, and actual response rates are generally quite low. The biggest challenge is to know how to select the optimal sequence of systemic treatments. This will be even harder in the future as more treatments become available. Thank you very much.